Okay, so good afternoon. Welcome back to part 3 of our lecture. And good afternoon. Welcome back to part 3 of our lecture in human disease states, male reproductive systems. So we took a look at this case of a 49-year-old man who presented with severe pain in the distal portion of his penis, which is characterized as sudden in onset. So after physical examination, the physician found out that the foreskin of the penis was retracted but cannot be rolled back over the glans penis. So the ER physician consulted a urologist who performed an emergency resection of the foreskin. So what is the most likely diagnosis? So balanoposthesis, epispadias, omphalocele, paraphimosis, phimosis. So actually many of the penile dysfunctions are common among males. In our case, which was a case of phimosis, is actually a situation where you have a very tight foreskin which was too small to be retracted over the glans penis. So this is common among uncircumcised males whose foreskin are not removed during circumcision. So that is a very common condition among our circumcised males. So although physiologic until the 3 years of age, phimosis after 3 years of age is considered as pathologic. So they often experience chronic infections and inflammations of the glans penis, which is called balanitis. So infection of the glans penis or inflammation of the glans penis is balanitis. And sometimes this is due to the fact that there is poor hygiene in the area. So circumcision can be used as a treatment after the initial infection is treated with a broad spectrum antibiotic. So it does not mean, however, that circumcision should be done among all males, but there is just this higher risk for phimosis among uncircumcised males. So our next problem is among penile diseases is your Peyronie's disease. Peyronie's disease is where you have a dense subcutaneous fibrous plaque on the tunica albuginea on the dorsal side of penis, causing lateral curvature during erection. So this when this happens, it usually affects older men. However, until today, the cause is yet to be established. If the curvature of the penis interferes with normal sexual intercourse and leads to dissatisfaction with sexual performance, then surgical correction is usually recommended. Then, if erectile dysfunction or infertility occurs, a penile implant can be considered in this case. Priapism. Priapism, painful, persistent erection, which is absent in the absence of sexual stimulation. So even though there is no stimulation sexually, the penis is still erect and refuses to relax. So this can be the result of a sickle cell disease, spinal cord injury, antidepressants like trazodone or antipsychotics like chlorpromazine, and of course secondary to penile trauma. So what are the other abnormalities? You have balanitis, which I've already mentioned earlier, which is inflammation of your glans penis. If the foreskin and the prepuce is inflamed, then you call that as balanopostesis. So combination of the inflammation of the foreskin and the prepuce is called balanoposteitis. Balanitis, inflammation of the glans penis, is commonly seen in an unhygienic or circumcised men because the collection of smegma is carcinogenic, and the lack of aeration causes irritation and inflammation. This accounts for an increased rates of penile cancer among uncircumcised males. Balanitis can be complicated by phimosis and meatal stenosis, leading to urinary retention. So what's the treatment? Treatment would include cleaning the area and the use of antibiotics. Bowen's disease or erythroplasia querat, they are both intraepithelial neoplasia. So your Bowen's disease is an intraepithelial neoplasia on the shaft of the penis or scrotum. It is associated with high risk HPV infection. For example, your HPV16, it presents with a gray solitary crusty plaque, typically on the penis or scrotum. It is a precancerous lesion and has a 10% chance of progression to squamous cell carcinoma. Your erythroplasia querat is similar to your Bowen's disease. However, it presents with red velvety plaques that typically involve the glands, and is the same as Bowen's disease. It is associated with high risk human papillomavirus and is a precursor for squamous cell carcinoma. Your Bowenoid papulosis are small, multiple red, brown, or fresh colored patches on the skin of the penis. It is a pre-malignant condition with about 2 to 3% chance of progression to carcinoma. And Bowenoid papulosis has been linked closely to high-risk HPV and is described as being between genital warts and Bowen disease of the penis in severity. So many cases of Bowenoid papulosis spontaneous regress, but close follow-up is required as it has malignant potential. Lastly, you have cancer of the penis, usually squamous cell carcinoma. Penile cancer is rare, representing less than 1% of cancers among the males, but cancer of the penis is frequently seen in unhygienic individuals and is closely linked with genital warts and high-risk HPV. So those are the diseases of the testes, of the penis. Let's now go to our next case, which is this one. Histologic examination of an excision specimen from a lesion on the dorsal surface of the penis reveals a papillary lesion with clear vacuolation of epithelial cells on the surface and extension of the hyperplastic epithelium into the underlying tissue along a broad front. Which of the following is the most likely diagnosis? A. Condyloma acuminatum. B. Bowen's disease. C. Erythroplasia of querat. D. Verrucous carcinoma. E. Squamous cell carcinoma. So, what do you think is the diagnosis here? So, this is a case of a verrucous carcinoma. So let's take a look at these diseases in particular. First, let's take a look at the diseases of the testes. The testes can have several abnormalities, including congenital problems, infectious problems, and other structural abnormalities. So congenital abnormalities include cryptorchidism, infectious diseases like orchitis and epididymitis, and Other abnormalities like torsion, varicocele, hydrocele, hematocele, and spermatocele. So let's go to this problem. The photomicrograph is a section from a testis removed from the inguinal region of a man aged 25. Which of the following statements about this condition is true? So this is this slide shows to you a section from a testis removed from the inguinal region. So this is an extrascrotal location of the testis. So this was a testis that failed to descend. Removed from man aged 25. So which of the following statements about this condition is true? A. It is bilateral in the majority of cases. B. Teratoma is the most common malignancy to arise. C. Risk of associated malignancy is reduced by orchiopexy. D. There is increased risk of malignancy in the contralateral testis. And E. Both Leydig and Sertoli cells are reduced in number. So what do you think this is? So this is a case of undescended testes. In a true statement among the following statements is that there is increased risk of malignancy in the contralateral testis. Let's now discuss this congenital abnormality, which we call cryptorchidism. Cryptorchidism is the failure of descent of one or both testes into the scrotal sac. It is often unilateral, and undescended testis frequently is palpated as a mass in the inguinal canal. So, most frequent location of an undescended testis is in the inguinal canal. There is an increased risk for germ cell tumors like seminomas or embryonal carcinoma even after the undescended testis is removed. So the complications of cryptorchidism is ipsilateral inguinal hernia. Of course, you have herniation, you have testicular torsion, the possibility that it will become twisted, trauma, and infertility. Management will involve orchiopexy, which decreases cancer risk if done before 10 years of age. If early enough the condition is corrected, either with the removal of the affected testis, or if it's caught early enough, correction of the undescended testis, then cancer risk is reduced. Let's now go to infectious diseases which affects your testis. You have orchitis and epididymitis. Orchitis is the inflammation of the testis by the mumps virus. So a very common cause of inflammation or orchitis of the testis, inflammation of the testis, is due to the mumps virus. This is usually unilateral. However, if it is bilateral, it may lead to sterility due to atrophy of the seminiferous tubules. Epididymitis, on the other hand, is an infection that can be caused by a variety of bacteria which infects your epididymis. So when you have epididymitis, usually can be caused by a variety of bacteria. For less than 35 years old, it can be caused by Chlamydia trachomatis and Neisseria gonorrhea. If it's greater than 35 years old, it can be caused by Escherichia coli and Pseudomonas aeruginosa. Tuberculosis infection can also start in the epididymis and travel to the seminal vesicles, prostate, and testicles. Patients often suffer from pain and swelling in the scrotum, tenderness, and a positive Prin sign. So if you recall in your physical diagnosis, how do you elicit the Prin sign to distinguish between epididymitis and testicular torsion, which both manifest as pain in the testes. So the print sign is when you lift the scrotum, of course lifting the testis with it, is that it it relieves the pain in the testes. Also for if it's testicular torsion, even if you lift the testis or the scrotum, it does not relieve the pain of the testis. So that is how you elicit the print sign. So you have a positive print sign if lifting the scrotum relieves the pain. Other abnormalities will include torsion, twisting of the spermatic cord, compromising blood supply to the testes, can also result from trauma to the testes or torcidism. This is a surgical emergency, so if you have testicular pain and then when you do the print maneuver and it does not relieve the pain when you lift the testis or the scrotum, then what you need to do is you have to refer the patient to surgery, because it can be a manifestation of torsion, testicular torsion, and it needs to be managed within 6 hours. On the other hand, varicocele is a condition by which you have dilated and tortuous vessels located in the pampiniform plexus and the spermatic cords that appears physically as a bag of worms on examination. The left testis is more likely to have a varicocele because its pampiniform plexus drains into the left renal vein before the inferior vena cava, causing increased pressure in the venous plexus. Any type of obstruction of the left renal vein, such as in renal carcinoma, can cause varicocele. Varicocele is the most common cause of treatable male infertility. Hydrocele. Hydrocele, on the other hand, is a collection of serous fluid that distends the tunica vaginalis. It is most commonly caused by a persistent processus vaginalis that enables communication between the scrotum and the peritoneal cavity. So this is the most frequent cause of enlargement of the scrotum in young boys, and usually when you do your examination, it is characterized by transillumination. So it can be distinguished from tumors by transillumination because the hydrocele transilluminate while your tumor do not. Hematocele, on the other hand, is a collection of blood in the tunica vaginalis. And spermatocele is a retention of cyst distended with fluid containing spermatozoa in the epididymis or rete testis. Okay, let's go to another case in this lecture. A 27-year-old man presents with painless scrotal swelling, enlargement. He reports a sensation of heaviness in his scrotum. He denies any history of fever, chills, nausea, or vomiting. Physical examination finds an approximate 1 centimeter mass in the superior portion of the scrotum, anteriorly located to the testis. Because the mass transilluminate, the diagnosis of hydrocele is considered. Which of the following is the best method to confirm that this mass is in fact a benign cyst and not a solid tumor? So you are being asked here, what is the best confirmatory test or diagnostic tool? So in this case, it's not Doppler ultrasound, it's not FNA, it's not surgical biopsy, it is not testicular scintigraphy, It is simply ultrasound. So you undergo imaging ultrasound. So this is what I have mentioned earlier, your hematocele and your spermatocele. Hematocele is collection of blood. In a tunica vaginalis, there's absent transillumination, and clotted hematocele requires orchidectomy, while spermatocele is collection of spermatozoa in the epididymis, and usually large ones should be aspirated or excised. Let's now go to the last portion of our lecture, which is cancer in the male reproductive system. So neoplasms are characterized into several types. One is you have your germ cell tumor comprised of your seminoma, which is about 50% of all germ cell tumors. The others includes yolk sac tumor, embryonal carcinoma, choriocarcinoma, and teratomas. You also have your interstitial non-germ cell tumors, which includes prostata, BPH, and adeno-CA of the prostate. Okay. Let's take a look at this case of a 44-year-old man presenting with a painless enlargement of one testicle. Physical exam reveals a single testicular mass that does not transilluminate. So the mass is resected, examined histologically, and radiation therapy is subsequently given based on pathology diagnosis. Which of the following best describe the expected microscopic appearance of this tumor? A mixture of malignant cytotrophoblastic and syncytial trophoblasts. B. Abnormal tissue derived from all three germ levels with scattered immature neural elements. C. Large tumor cells with abundant eosinophilic granular cytoplasm and rare intracytoplasmic rhomboid crystals. D. Numerous lymphocytes in the fibrous stroma between groups of tumor cells having distinct cell membranes and clear cytoplasm. And E. Sheets of undifferentiated tumor cells having focal glandular differentiation. So in this case, which leads us to conclude that this is probably a seminoma, you will have numerous lymphocytes in the fibrous stroma between groups of tumor cells having distinct cell membranes and clear cytoplasm and sheets clear cytoplasm. So your seminoma, which is the most common germ cell tumor of testis, as a large, soft, white demarcated, well-demarcated gray-white tumor that bulges from the surface of the affected testis. Seminoma is confined beneath an intact tunica albuginea, and it is characterized by large cells with distinct cell borders, pale nuclei, and prominent nucleoli. So they have somewhat like a fried egg appearance, as well as a lymphocytic infiltrate. Seminoma is associated with the increase in HCG, human chorionic hormone, and placental-like alkaline phosphatase. It mainly affects males between the age of 15 and 35 years old, and seminoma metastasizes via the lymphatics and is radiosensitive with an excellent prognosis. So that is your seminoma. Let's now go to another type of cancer, which this case illustrates. A 27-year-old man presents with testicular mass, which is resected and diagnosed as being a yolk sac tumor. Which of the following substances is most likely to be increased in this patient's serum as a result of being secreted from the cells of this tumor? So acid phosphatase, B. Alpha fetoprotein, C. Alkaline phosphatase, D. HCG, and E. prostate-specific antigen. So of course we know that this is a yolk sac tumor. A yolk sac tumor has the presence of your alpha fetoprotein. So in summary, when you look at your yolk sac tumor, it's characterized by a large, well-demarcated tumor, and this is most common in children less than 3 years old, with the presence of alpha fetoprotein within the cytoplasm of neoplastic cells and the presence of hyaline globules. Schiller double bodies, which are structures resembling primitive glomeruli, are a distinctive feature of yolk sac tumor. So when you see the word Schiller double bodies, think yolk sac tumor. So as I've mentioned earlier, alpha fetoprotein can be demonstrated within the cytoplasm of these neoplastic cells, and this kind of cancer tumor is most common primary testicular neoplasm in children less than 3 years old. But of course, you also have embryonal carcinoma, which are ill-defined invasive mass with a foci, hemorrhage, and necrosis. Metastasis is common. It's associated with increased HCG. And you also have your choriocarcinoma, which are primarily tumors that are small and non-palpable, characterized by small cuboidal cells intermingled with eosinophilic syncytial cells representing cytotropoblastic and syncytiotropoblastic differentiation, and your HCG is elevated. Lastly, you also have your teratomas, which are differentiated neoplastic cells along somatic cell lines. They are characterized by firm masses, often containing cysts and areas of cartilage, mature, immature, malignant transformation, mixed transformation, and of course both HCG and AFP are elevated. So your teratomas can be divided into 3 major variants: mature, immature, with or without malignant transformation, and mixed. Mature teratomas are fully differentiated tissues from multiple germ cell lines, but for example, they might be nerve tissues, cartilage, adipose, bone, or epithelium in a random array. You can have immature tissues. You have immature somatic elements reminiscent of those in developing fetal tissue. And mixed can be combination of teratoma, embryonal carcinoma, and yolk-sac tumor, and in this case HCG and AFP are elevated in mixed tumor. You also have your interstitial cell tumors characterized by your Leydig cell tumor, Sertoli cell tumor, and malignant lymphoma. So let's go to your non-germ cell tumors. Leydig cell tumor arises from Leydig cells, contains Reinke's crystals. They are benign in nature, produces androgen, leading to gynecomastia in men and precocious puberty in children. You also have Sertoli cell tumor, which arise from Sertoli cells. It can lead to gynecomastia, loss of libido, and aspermia, which basically leads to feminization of the patient. It's a benign condition and could be managed by orchidectomy. Lastly, let's go to your prostate diseases. You have your prostatitis, BPH, and adenocarcinoma of the prostate. This case is a case of a 47-year-old man presenting with sudden onset of fever, chills, and dysuria. Rectal examination finds the prostate gland to be edematous and very sensitive. Examination is quite painful. Microscopic examination of the prostate reveals the presence of numerous neutrophils. Which of the following organisms is the most likely cause of this illness? Bacillus calmette-guerin, Escherichia coli, Proteus mirabilis, Staphylococcus aureus, and Ureaplasma ureaticum. So of course, you will note that the most common cause of infection of the prostate is your E. coli and your gram-negative rods. So prostatitis, which is inflammation of prostate, is characterized by dysuria, urinary frequency, and lower back pain, and of course polylocalized pelvic pain. It could be chronic or acute. If it is acute, it is caused by E. coli and gram-negative rods, and characterized by microabscesses. The prostate is often tender and buggy. It's like soft. Leukocytosis is present and there is fever. If it's chronic, there is tissue destruction, increased fibroblastic inflammation, maybe due to recurrent UTI or sexually transmitted disease. So, diagnosis of prostatitis is usually clinical. If you have greater than 15 leukocytes per high-power field in prostatic secretions, then you confirm the diagnosis. You treat it with the antibiotic, particularly your fluoroquinolones and your TMP SMX, trimethoprim sulfamethotrexazole, and your ceprofloxacin. Now we have a case of a 16-year-old man presenting with urinary frequency, nocturia, dribbling, and difficulty in stopping urination. Rectal examination reveals the prostate to be enlarged, firm, and rubbery, and needle biopsy reveals increased numbers of glandular elements and stromal tissue. Blood glands are found to have a double layer of epithelial cells. Prominent nuclei or back-to-back glands are not seen. Which of the following is the most likely diagnosis? A. Atopic prostatitis. B. Atypical small asana proliferation. C. High-grade prostatic intraepithelial neoplasias. D. Benign prostatic hyperplasia. E. Prostatic adenocarcinoma. So you have an enlarged prostate, but it's rubbery. The enlargement is diffused, is smooth. So those are the characteristics that you see of benign prostatic hyperplasia. So that is the most benign BPH, or benign prostatic hyperplasia, is the most common diagnosis. One of the more common diagnoses among males in terms of prostate pathology. So benign enlargement of the prostate gland due to serial perforation, usually occurring in the central zone. You have seen the central zone earlier in the schematic diagram of the prostate, commonly seen in men greater than 50 years old. So males greater than 50 are at risk for BPH. That is why it is mandatory in the clinics that when you see a male greater than 50, that you do a direct rectal exam to rule out the presence of benign prostatic hyperplasia, especially if there is a family history of BPH or cancer. This is associated with age due to increase in estrogen levels, increased androgen receptors, and increased sensitivity to dihydrotestosterone. Presentation in the clinics will include urgency, frequency, nocturia, dribbling of urine, post-stream sensation, incupoidic, and incontinence. Usually you do your direct rectal exam to diagnose these cases. You will find a firm, smooth, and uniformly enlarged prostate on direct rectal examination. Do you treat this with several non-selective alpha blockers, including doxazosine, pratuzine, terazosine, and selective alpha blockers like your tamsulosin, and of course your the newer 5-alpha reductase inhibitors, your finasteride. Or if you think you can manage it surgically, then you can do your TURP, transurethral resection, or prostatectomy. Another case of a 67-year-old man found in rectal exam to have a single hard irregular nodule within his prostate. A biopsy of this lesion reveals the presence of small glands lined by single layer of cells with enlarged prominent nucleoli. From what portion of prostate did this lesion most likely originate? A. Anterior zone, B. Central zone, C. Peripheral zone, D. Periurethral glands, E. Transition zone. Now what you will notice, this is different from the previous case where you have enlargement also of the prostate, but in the previous one it was diffuse enlargement, and the prostate was smooth. In this case, upon examination, the prostate was irregular, hard, and the nodule found was a single solitary nodule, so it was not diffuse enlargement. So now you would suspect that this is probably cancerous. And usually when you have cancerous lesions, they usually come from your peripheral zone. So the answer here is peripheral zone. So adenocarcinoma of the prostate mostly comes from the peripheral zone. 70% of them occurs in 20 to 30% of men greater than 50 years old, and 90% of men greater than 70. Most are ever very slow growing and never present in lifetime. This is due to declining androgen levels, and recursive changes are mostly in peripheral zones. So the presentation has hard irregular mass during direct rectal examination. It will have elevated PSA, and of course the lymphatics and hematogenous vessels are possible sites for spread, but also direct invasion is possible. So diagnosis is by DRE, stony hard with obliteration of the median sulcus, or you take a look at your PSA. If it is greater than 10 nanogram per ml, then it's suggestive of your adenocarcinoma. If it's greater than 35, now you will suspect that it is advanced cancer. You will see alkaline phosphatase. If you already have hepatic or bone metastases, and if you do your radiology, you will see sclerotic metastases in lumbar vertebrae and pelvic bones. Treatment is usually by radical prostatectomy if it is early in the disease. This is curative. However, if it's already advanced, you only do palliative treatment like orchidectomy, anti-androgens like flutamide. You can do radiation, and you could do your GnRH agonists treatment. So that concludes our discussion on pathologies associated with the male reproductive system. With that, thank you very much. I hope that you learned something this afternoon, and you will continue reading on your own and most of the questions that will appear in final examinations have already been discussed in this lecture or has been given in the quiz this afternoon. Good luck, and thank you very much for watching and tuning in, and see you